Good afternoon, everybody. I'm just gonna wait just a minute or two, but we want to go ahead and get started on time today. We do have a hard stop at 3:15, so just waiting a few more seconds and then we will get started. Just a couple reminders, please make sure to put your questions in the Q&A. Chat can be used for chatting it up or any technical issues you're having. Please feel free to post the questions as they occur, and I'll be asking them probably starting around halfway through the presentation. We'll start posing some of those questions. And it looks like we've pretty much, I think we're about there. So I'm Julie again. Most of you have seen me throughout the conference, and I'm actually really excited about this presentation. This is one that I'm particularly interested in, and I really appreciate Dr. Smith coming and talking to us about this. This is a session on long-term complications from COVID-19. Our speaker this afternoon is Dr. Nathaniel Smith. Dr. Nathaniel Smith is currently the Deputy Director for Public Health Service and Implementation Science at the Center for Disease Control and Prevention. He previously served as the Secretary of Health, Director of State and Health Officer, Deputy Director of Public Health Programs, Director of the Center for Public Health Practice, Associate Director for Science of the Center for Health Protection at the Arkansas Department of Health. Again, we will start posing some of the questions you put in the box about halfway through the presentation, and then I will post the code at the end of the session in the chat box as well as announcing it. So Dr. Smith, thank you again for joining us, and I'll pass it over to you.
Thank you, Julie. Again, I'm Dr. Nate Smith. I do serve as Deputy Director for Public Health Service and Implementation Science at the U.S. Centers for Disease Control and Prevention. My background and training is as an infectious disease physician and an epidemiologist. I am not going to pretend to be an expert in long-term complications of COVID-19. I think we're all learning when it comes to COVID and particularly the long-term complications. But what I have to share with you today is really a team effort from those who have been studying this very carefully at the CDC, as well as data from others around the world who have been looking at what's been happening with COVID and what's been happening in terms of those post-COVID conditions. I don't have any relevant financial associations to disclose. In terms of our learning objectives, we're going to begin by talking a little bit about the epidemiology of COVID-19 in the United States. Then we'll talk a little bit on progress in controlling the spread of COVID-19, as well as protecting those most at risk. The majority of the talk, though, today will be focused on major clinical manifestations of COVID, particularly those post-COVID conditions. Starting with the basics of COVID. COVID-19 is caused by the virus SARS coronavirus 2, which is one of 7 known human coronaviruses. Now, there are 4 human coronaviruses with names that only virologists could love, and they cause mild seasonal upper respiratory tract infections. So you don't need to know about them. You don't need to know their names. There are 3, though, that cause more serious illness, and these all 3 have recently crossed over from animals to humans. Now, all of them are related to viruses that are found in various bat species, and at least SARS coronavirus 1 and MERS coronavirus have passed to humans through other mammalian hosts. For example, Mediterranean respiratory virus is most commonly passed to humans through camels. SARS coronavirus 2, as the name would suggest, is most similar to SARS coronavirus 1, which is the cause of SARS, severe acute respiratory syndrome. Of these 3, of course, SARS coronavirus 2, the cause of COVID-19, is much more widespread. And it's what's caused our pandemic that we're all living through, which is why I can't be with you in person, but hopefully next year. In terms of the basic structure of coronaviruses, they get their name from these spike proteins, which on an electron microscope, they project from the surface of the virus, and they look to some virologists like a crown. And so corona comes from the Latin word for crown. So that's why it's called coronavirus. These spike proteins are what allow the virus to attach to the cells of the body when they infect. They are also the target for antibodies, both monoclonal antibodies, which we use to try and treat early infections, but also the spike protein is what we use in the vaccines to elicit antibody responses that will target the spike protein on the surface of the virus and neutralize it. So the spike protein is very important, and it's genetic variations in that spike protein that cause these variants that you've heard about. The other protein that I want to highlight is the nucleocapsid protein, which is in the inner part of the virus. The reason why that's important is that if you want to tell whether a person's antibodies are from vaccine or whether they're from natural infection, we can test for antibodies to both the spike protein and the nucleocapsid. If the antibodies are from a vaccine, then only spike protein antibodies will be in the blood. If the antibodies are from natural infection, there'll be both antibodies to spike protein as well as to the nucleocapsid protein, which is on the inner part of the virus. Enough virology. If you haven't already fallen asleep, we'll move on to something a little bit more interesting. Let's start by talking about how SARS is spread. I think we're all pretty familiar with that by now, but just to point out that it's really respiratory droplets that carry infectious virus. These respiratory droplets range in size. Most of them are less than 10 microns, and they're referred to as aerosols. You can see from this graph that different activities produce different volumes of droplets. Beginning with the green on the bottom, that's normal respiration, normal breathing. If you start talking, then you get more respiratory droplets. Loud talking or normal singing, even more. And the most respiratory droplets, these aerosols, are produced by loud singing. Then, of course, heavy breathing, like during exercise, would produce more respiratory droplets than normal breathing. Most infections are actually transmitted by people without symptoms, either those who never develop symptoms, asymptomatic infections, or people who have not yet developed symptoms. And that's been an important finding, important challenge for us in slowing the spread of COVID-19, because many of the cases are acquired before we even know the source patient is sick. That's why it's very important that we do testing as well. The peak of infectiousness occurs around day 5. And then by 14 days, very, very little infectious virus left. Now, if we do a test with a PCR looking for the virus, that may remain positive, though much longer than those 14 days, may be positive for weeks or even months. And that's why we don't recommend repeat testing for someone within the first 90 days of infection. If someone's been infected, known infection, known positive test within 90 days, we don't recommend repeating that test because it could be positive just because of residual virus. Now, if someone tests positive more than 90 days after a previous positive test, well, that that may be reinfection. The chance that that's reinfection increases after 90 days. The virus, SARS coronavirus 2 that causes COVID-19 has been isolated, either detected by PCR or isolated by culture from a variety of sample types. But the only samples from which the only sources from which we've observed transmission are really respiratory sources. Nasopharyngeal swab, oropharyngeal swab, sputum, those all we can find virus, and we know that it's transmissible in that way. But this is just to give you an idea of the types of samples that have been tested, that do test positive, at least from time to time. In terms of the symptoms, I think most of us are very familiar with that as well. Many of the symptoms of COVID-19 are pretty non-specific. Fever, cough, shortness of breath, fatigue, muscle or body aches, headaches, pretty much indistinguishable from flu-like symptoms. Loss of taste and smell is a bit more specific though. It doesn't occur in everyone, but if it does suggest COVID-19 is the cause. Some people with COVID have GI symptoms, especially at the beginning, nausea, vomiting, diarrhea. Symptoms typically appear between 2 and 14 days after exposure to the virus. The manifestations, clinical manifestations of COVID-19 can range from no symptoms at all, asymptomatic infection, to mild flu-like symptoms, to more severe illness and even death. There are some serious long-term complications, which we'll talk about later in this presentation. In terms of the acute complications though, pneumonia, respiratory failure, septic shock, these are all manifestations of severe COVID-19. COVID-19 can affect the heart as well. Cardiomyopathy can affect the kidneys with acute kidney injury. And of course, there are complications just of being seriously ill in the hospital or in the ICU that are a part of it. Some people are at increased risk for severe illness. The older a person is, the more likely they are to get severe manifestations of COVID. Even young adults and even children with certain underlying medical conditions are at increased risk for serious illness from COVID-19. The point here is that people who are at increased risk or who live with people at increased risk or visit them need to take extra precautions to keep themselves from getting COVID-19, particularly vaccination. Vaccination is recommended, for all those age range 5 and up, but especially important for those at increased risk and for those who are in contact with them. This is not a comprehensive list of underlying medical conditions that increase the risk for serious COVID-19, but these are some of the conditions that have been associated with severe outcomes. Some of the conditions that are the strongest risk factors include dementia, diabetes, and heart disease. Two of the most common high-risk conditions, though, are smoking and obesity. I want to highlight pregnancy here. Pregnant women can have particularly severe manifestations of COVID-19. It can be very serious, even causes death in some cases, particularly towards the time of delivery. And so it's critically important that pregnant women get vaccinated, if at all possible. In terms of the epidemiology, this slide is about, now it's about 3 weeks old, but you can see we've had our ups and downs with with COVID. In terms of the number of cases, you can see we've had various waves. The largest was last winter. This little bump here was the Alpha variant. And then we got down this summer to really the lowest levels of cases we had seen since the beginning of the epidemic, the pandemic. But then here was the Delta variant, and it went up and had been coming down. The bad news is that over the last 2 or 3 weeks, we've actually seen it start to creep up again, driven mostly by increases of cases in the northern states in the United States. Now you can see that the deaths have followed suit. Far too many deaths, far too many people have lost their lives to this virus, to this pandemic. But a good piece of news is that the fatality ratio, the proportion of deaths to cases has decreased over time. And we've not seen as many deaths per case in this most recent wave as we have certainly at the beginning. This is looking at the level of community transmission, and this is about 3 weeks old as well. Hasn't changed a lot. You can see, although we had been trending in the right direction, downward, most of the country is still in the high transmission range. Almost 70% of counties as of today are categorized as high transmission, and over 85% of counties are either high or substantial transmission. At least at this time, we are doing a little bit better in the south than in the north, but you know, that seems to swap back and forth as time goes on. COVID-19 has been serious. It was the third leading cause of death last year in 2020, right behind heart disease and cancer. I'd like to talk a little bit about prevention. We won't do a comprehensive presentation on prevention and mitigation strategies, but one that seems to generate a lot of discussion is masks. Recently had a healthcare professional say, "Show me the evidence that masks work." Well, you know, yeah, there is quite a bit of evidence to show that. I would direct your attention to the science brief on community use of cloth masks to control the spread of SARS coronavirus 2 on our CDC website, all the articles and publications that you'd want on that. I'm going to summarize them very briefly here. The first is laboratory assessments of masks. And in this case, we're focusing on the cloth masks that are used for community prevention. Now, the main utility of cloth masks is what we call source control, to prevent the person wearing the mask from breathing out infectious aerosol particles into the air. But there is some benefit in terms of filtering protection, protecting the wearer from breathing in those particles from the air that around them. In terms of source control, blocking respiratory particles from the environment into the person, from the person wearing the masks out into the environment. Multi-layer cloth masks do substantially block these respiratory particles in the 1 to 10 micron size range. Reductions as much as 50 to 70% have been seen with cloth masks. Some of the better designed cloth masks are on par with the surgical masks, the paper masks that we wear in the hospital or healthcare settings. In terms of filtering protection, not quite as effective for protecting the wearer, but they can provide some protection, and that protection can be improved by cloth masks that have multiple layers, and particularly if the fit is tight. And there are different strategies for doing that: double masking or wearing a ring around to seal it a little tighter at the edges so that air doesn't leak around. Lab assessments are not the only evidence base to show the benefits of masks in terms of preventing transmission of COVID-19. We have epidemiologic investigations as well. There are some high-risk exposure events that have given us the opportunity to really see how masks work, how helpful they are. As an example, the outbreak of COVID-19 on the USS Theodore Roosevelt gave an opportunity to look at how protected those who were wearing face coverings were versus those who weren't. And we saw a 70% reduction in the risk of infection for those who were wearing face coverings. This is also consistent with what we've seen in retrospective case control studies of exposed contacts, which also showed about a 70% protection from wearing masks. And household surveys. In household surveys, if mask use among the household members was started before the index case developed symptoms, the risk of infection was reduced almost 80%. Of course, we've also seen in air travel, when universal masking is in place, we've not really seen any infections transmitted, even when there's an infected passenger, as long as everyone is wearing a mask. Probably the most effective prevention, well, I will say not probably, the most effective way of preventing COVID-19 transmission and stopping the pandemic is vaccination. And this graphic, it's an infographic, goes over a couple of issues that I'd like to briefly cover. First of all, the vaccines are effective in preventing infection. They're not 100% effective, especially with this Delta variant. We do see breakthrough infections, but even among those who do get infected, the likelihood of serious illness, hospitalization, or death is dramatically reduced. The second is it really looks like the immunologic protection from the vaccine is better than that from natural infection. That's a little bit unusual, but those are what the data show us, is that those who have been vaccinated are less likely to get infected than people who have been already infected, how likely they are to get reinfected. So vaccine protection is actually better than protection from natural infection. And if you add those together, if someone has already been infected in the past and then you vaccinated them, they get very high levels of protection. So it's still beneficial even to those who've already been infected in the past. COVID vaccines don't have any live virus in them, so they cannot give someone COVID-19. Now, they stimulate the immune system and people may feel achy, they may have a reaction there, but it doesn't cause COVID-19. And then COVID-19 vaccines will cause a positive antibody test for the spike protein, but they don't cause a positive result on the viral test that we use to diagnose people. They won't cause a positive PCR or an antigen test. They don't interfere with those test results at all. The three vaccines that we have available to us here in the US are the Pfizer vaccine and the Moderna vaccine, which are both messenger RNA vaccines, and then the Janssen or Johnson & Johnson vaccine. The mRNA, the Pfizer and the Moderna are 2-dose series. For Pfizer, it's 3 weeks apart. For Moderna, it's 4 weeks apart. The Pfizer vaccine has recently been authorized for ages 5 and up. For children ages 5 to 11, it's a different dose. So there's a pediatric dosage of it, but it's still a 2-dose series, 3 weeks apart. The Moderna is currently only authorized for ages 18 and above, although it looks like they will be applying for authorization in children as well. Now, for those who have moderate to severe immunocompromise, it is recommended that they receive a booster dose of one of the mRNA vaccines, either Pfizer or Moderna, at least 4 weeks after completing the primary series, at least 4 weeks after the second dose of the mRNA, messenger RNA vaccine, the Pfizer, the Moderna series, after that's completed. Now, for those who have received the Johnson & Johnson, the J&J vaccine, a booster is recommended at 2 months for all those who received the J&J vaccine. In terms of what we've seen here in the US, most of those who have been vaccinated with the Pfizer, followed by Moderna, and then a smaller number with the J&J vaccine.
Can I ask
Safety.
you a quick question? Because it applies
Sure.
to and just one question. The question is, will breakthrough infections for those who are vaccinated decrease over time?
That's a good question. It does look like when people receive a booster dose, they are less likely to have a breakthrough infection. And so as more people get a booster dose, we are likely to see fewer breakthrough infections. There'll always be some. No vaccine is 100% protective, but what we're really trying to do is prevent serious illness, hospitalization, and death. And even unboosted, these vaccines are very effective for that. Of course, the less transmission we have in our communities, the more people we get vaccinated, and the less transmission we have, the fewer cases we have, the fewer breakthrough cases we'll have as well. Julie, any other questions before I go on?
I don't think so.
Okay, I'll continue. Safety is always an active discussion when it comes to vaccine. And both the FDA and CDC are very involved in safety assessment and monitoring. Both FDA and their advisory committee, as well as CDC and our advisory committee, the Advisory Committee on Immunization Practices, review the safety data before authorizing or approving. And then after authorization or approval, we continue to watch very carefully, monitoring for safety. And we have a number of safety systems in place, including the VAERS system, the Vaccine Adverse Event Reporting System, as well as the vSafe system. And I would say, given the number of vaccines that have been given and the double system for looking for adverse effects, this is probably the most observed vaccine in the history of mankind. And so we have picked up safety signals and addressed those, but this is in terms of safety, the monitoring on this has been as good or better than any other vaccine that we have. I'd like now to turn to the post-COVID conditions and really spend the rest of our time together on this, because I think that this is an area that's of particular interest or particular concern to rehabilitation professionals. The terminology used for these longer-term health effects from SARS coronavirus 2 infection is not really standardized at this point. You'll hear the term long COVID or long haulers, post-COVID syndrome. For the purpose of this presentation, I'm going to try and consistently use post-COVID conditions, just so you know what I'm talking about. And what do we need to know about them? Well, what is it? How many people develop it? How long does it last? What causes it? Whom does it affect? And what can be done to prevent it? These are all active areas of investigation. We have some information, which I'll share with you, but there are still many unknowns, questions that have not been fully answered yet. To more carefully define what we're talking about, when we're talking about post-COVID conditions, we're really talking about those health effects that are seen 4 weeks or longer after the initial infection. So when I'm talking about post-COVID conditions, or people are talking about long COVID, we're talking about symptoms or signs that occur or that persist 4 weeks or longer after the initial infection. Post-COVID conditions is a umbrella term. It includes a wide range of physical and mental health consequences. And some of the more common ones include respiratory cardiac symptoms, fatigue, sleeping difficulties, depression, anxiety, palpitations, joint pain, and particularly important to you all, post-exertional malaise. And I'll insert a comment here. When you're working with these individuals in rehabilitation, you have to be careful not to overexert them and precipitate this post-exertional malaise. You got to take it careful with them. These are medically complex situations, and the symptoms frequently are not explained by testing abnormalities. There's not a single test that says this person has a post-COVID condition. We'll talk about the range of things that have been seen. Some of them have objective evidence that we can see on tests, but many people who suffer from these conditions, they have symptoms that we don't have a good test for, laboratory test for, and we've got to work with them, take their word for it, and take them seriously. That's many of the people who report these post-COVID conditions. They report frustration with providers who either don't know what they're talking about when they report these symptoms or don't take them seriously. This is an emerging area, and so many clinicians are unfamiliar with it. But these patients have real challenges, and we need to listen and learn and recognize that we're all on the steep learning curve when it comes to these conditions. The World Health Organization has recently published a clinical case definition, but again, we're still learning. The post-COVID conditions again include a variety of different types of conditions. Some are the general consequences of illness and hospitalization, the post-ICU syndrome, other complications of being severely ill or hospitalized, and others are more specific to the SARS coronavirus 2 infection. They may be system-specific pathology, either the lung or the heart or neurological. They may be symptoms without clear underlying pathology, the chronic fatigue syndrome type of setting, or dysautonomia. And sometimes there are objective findings that are of unclear clinical significance. We're not sure exactly what they mean. And there's overlap between these. And so each person, each patient has a unique experience. We're still learning what some of these syndromes look like, but we need to take each patient as they come to us. In terms of how common these are, there's a number of studies that have been done. This is one from CDC, looking at those who self-reported COVID-19 or SARS coronavirus 2 infection. Many of them had persistent symptoms. Common symptoms were fatigue, change in smell or taste, shortness of breath, cough, headache, and persistence was very common. Over half of these patients had persistent symptoms. So this is broken down. I don't want to confuse you. Some of these had positive tests, and others, were diagnosed symptomatically or syndromically. There's plenty of other data slides that will talk about this, so we'll move on. Prolonged symptoms are common even among patients with mild COVID-19 who don't require hospitalization. So it's not just those who are severely ill that are getting these post-COVID conditions. In several different surveys from different parts of the world, we've seen that a third to half of the patients with mild acute COVID-19 had persistent symptoms 2 to 4 months after infection. And 9% of them reported these to be severe. And many of these symptoms were new. They were symptoms that they didn't have during their acute infection. A CDC study of non-hospitalized adults with COVID-19 showed that they had pretty high levels of healthcare utilization 1 to 6 months after diagnosis. 2 out of 3 patients with COVID-19. Remember, these are non-hospitalized adults. 2 out of 3 had an outpatient visit within 1 to 6 months of their infection. And common complaints were chest or throat pain, shortness of breath, fatigue, and cough. These symptoms tended to decrease over time, but some persisted beyond 120 days. This is a study from China of hospitalized patients. And it showed that 3/4 of the patients who had been hospitalized with COVID-19 had at least one ongoing symptom 6 months after their acute illness. The most common symptom was fatigue or muscle weakness, followed by shortness of breath, sleeping difficulties, anxiety or depression, and interestingly, hair loss. Altered sense of smell, palpitations, and joint pain were also reported. Again, this is 3/4 of the patients who had been hospitalized with COVID-19. This is a different study from the UK, and it was looking at people who had been hospitalized with COVID-19 and what was their risk of various conditions over time after discharge compared to people in the general population. And they found that they had increased risk of major adverse cardiovascular events, diabetes, chronic kidney disease, and chronic liver disease. Now, how do we explain all this? Not absolutely clear, but we are seeing in especially those who are had severe COVID, were hospitalized, that they're having a lot more adverse outcomes post-COVID than you would expect in the general population. This is a CDC analysis of electronic health records, looking at late onset conditions in adults. And then this is looking at both hospitalized and non-hospitalized adults. Now, the percentages here are smaller because these are specific defined conditions that they were looking for. The 5 identified late onset conditions are respiratory, cardiovascular, undefined chest pain, actually urinary and neurologic. So they were looking for specific things here. One of the findings that was interesting is that COVID patients who were not hospitalized, outpatient adults, were almost 3 times more likely to experience an acute pulmonary embolus than the other outpatients that were used as control patients. The prevalence and the duration of these post-COVID conditions varies from study to study, depending on which part of the world and what patient populations were being studied. Outpatients, mild disease, hospitalized patients, but we are consistently seeing various types of post-COVID conditions. Among those hospitalized, the frequency of post-COVID conditions is higher, as you might expect. But even those with mild disease can have post-COVID symptoms or conditions. I'd like to turn our attention in this part of the presentation to objective clinical findings in multiple organ systems in people with post-COVID conditions. But I want to remind you that many of our patients with post-COVID conditions don't have these objective findings that you could test on in a lab or see on a radiographic study. They have symptoms that may not be explainable by the tests that we're using, yet they still have serious conditions and in some cases debilitation. And you may see many of these patients if you haven't already. And And remember, we're looking at some objective findings, but this is not true of every patient. And just because a patient doesn't have a specific test result doesn't mean they don't have a serious post-COVID condition. As you might expect, lung or pulmonary conditions are a frequent cause of post-COVID conditions. And this study from China looked at hospitalized patients 6 months after their hospitalization. And even among those with the mildest disease, those who did not require supplemental oxygen while they were in the hospital, they still had over 20% of them had reduced pulmonary function 6 months after their hospitalization, as measured by a 6-minute walk test or a DLCO assessment, diffusion capacity for carbon monoxide. Now, for those who were sicker during the hospitalization, who either required supplemental oxygen or required ventilation, either non-invasive or invasive mechanical ventilation, the rates of pulmonary dysfunction 6 months after discharge were even higher. Somewhat surprisingly, neuropsychiatric conditions are a very frequent cause of post-COVID conditions. And that's not fully understood at this point, but I'll just share with you the data. This is a study from the UK, and they looked at neuropsychiatric diagnoses 6 months after acute infection. They found that 33% of adults had received a neuropsychiatric diagnosis within those 6 months after infection. And in 12% of the patients, those diagnoses were new. So you can either get either a worsening of a pre-existing condition or a new condition. And the most common one you can see here, mood anxiety or psychotic disorder, substance use disorder, insomnia, etc. We'll dive into this a little bit more in the subsequent slide. What I'd like to say is that it was 33% overall for the hospitalized patients or those who were in the ICU. The rates of neuropsychiatric diagnoses in the first 6 months after discharge were even higher. The way they did this study is they used a comparator group, in this case, those patients who had influenza. So they compared people who had been diagnosed with COVID-19 versus those who had been diagnosed with influenza to look at the frequency of these neuropsychiatric diagnoses after infection. And they found that all psychiatric illness was more frequent among those who had been diagnosed with COVID-19 than those with influenza, over twice as common. Mood disorder, almost twice as common. Anxiety disorder, over twice as common. They used a second comparator group, which included not just those with influenza, but with influenza or other respiratory tract infections. And they compared those diagnosed with COVID-19 versus those with other respiratory tract infections. And they looked at neurologic diagnoses. And neurologic diagnoses like intracranial hemorrhage were more common in those who had been diagnosed with COVID-19 than those with other respiratory tract infections. Ischemic stroke, higher in patients with COVID-19. They looked at other neurologic diagnoses, myoneural junction or muscle disease, much higher incidence than the comparator group. Nerve root plexus disorders, somewhat higher as well. Switching to some of the mildest infection, these are young adults with mild or moderate COVID-19. Again, healthy populations, Looking at them a median of 85 days after infection, able to detect lower cognitive scores than in healthy controls. And the areas that were most affected were attention, concentration, and short-term memory. Again, these are somewhat subtle findings, but even in healthy adults, healthy young adults with mild illness, there's still cognitive dysfunction, some cognitive effects months after infection. This is an area that is very interesting, although not fully explained. COVID-19, SARS coronavirus 2 infection can be associated with new or worsening of chronic conditions. Looking at kidney disease among hospitalized patients 6 months after, those who had acute kidney injury, over a third of them had decreased GFR 6 months later. Not terribly surprising. But among those who did not have acute kidney injury when they were in the hospital, 13% of them had a decreased GFR, which was maybe a little bit unexpected. Looking at heart disease, among hospitalized and outpatients, 2 months follow-up, decreased left and right ventricular ejection fractions were seen compared to healthy controls. And 60% had evidence of myocardial inflammation on MRI. The heart conditions have been seen in other studies. This is a VA healthcare system study looking at COVID-19 survivors a year out compared to historical controls, and they found increased risk of cerebrovascular events, dysrhythmias, inflammatory diseases of the heart, and ischemic heart disease. There are other conditions that have been seen post-COVID. Among hospitalized patients, 6 months follow-up, new onset diabetes mellitus was noted. And there have been reports of diabetic ketoacidosis and subacute thyroiditis. Again, not fully explained, but there's some things going on here. The COVID-19 pandemic has really uncovered huge health disparities, not just in the US, but around the world. And people who are at higher risk for infection, SARS coronavirus 2 infection, as well as being at increased risk for severe infection, may also be at higher risk for these post-COVID conditions. So looking at those who are particularly susceptible, racial and ethnic minorities, older populations, those who are clinically complex, and those living in rural areas. They may all be at increased risk for these post-COVID conditions, as they are at increased risk for infection and severe disease in the first place. A reminder, we can see post-COVID conditions not just in adults, but also in children. This is post-COVID conditions in children who were hospitalized for COVID-19. In this study, post-COVID conditions were more likely in children who were older than those who are younger. And most of the common symptoms were similar to those seen in adults. In this study of non-hospitalized children, they also experienced post-COVID conditions, although less frequently than among adults. Of course, they also may be less likely to be identified. People are not thinking of post-COVID conditions necessarily in children. Now, those children who have developed this multi-organ inflammatory syndrome, they also seem to be at increased risk for post-COVID conditions. Someone asked earlier about breakthrough infections, people who have been vaccinated but then got infected anyhow. Those infections tend to be milder, much less likely to be hospitalized or to die from COVID-19. But we are also seeing post-COVID conditions amongst breakthrough infections, vaccinated people who got infected anyhow. In this, in one study among healthcare workers in Israel, almost 20% of these breakthrough cases had at least some persistent symptoms more than 6 weeks after their infection. And this was in the setting of Alpha variant. This was before Delta variant. A UK case control study, though, found that breakthrough infections among people vaccinated were only about half as likely to develop post-COVID conditions as infections in people who were unvaccinated. So there does seem to be protection there, although not complete protection against post-COVID conditions. So we know that vaccines prevent infections, they prevent transmission. They're likely to also prevent post-COVID conditions, although occasionally we do see post-COVID conditions in breakthrough infections. Now, this is an important question, especially for rehabilitation professionals. How frequently do post-COVID conditions result in disability? The answer to that is not completely known. Most patients, fortunately, do slowly improve over time. A study from China showed that 12 months after infection, 88% of those infected were able to return to work. But we don't really fully know what that looks like in all the populations, and it's likely to vary by a specific population, the kind of work that they do, other socioeconomic factors. But given the size of this pandemic, even a 1% disability rate at 1 year would be huge in terms of the number of people requiring services. Evidence of disability associated with post-COVID conditions. This was an MMWR study published earlier this year that compared COVID-19 patients with post-COVID conditions who were in rehabilitation compared to cancer patients in rehabilitation. And compared to the cancer patients, the post-COVID patients had poorer physical health. They had more difficulty doing usual work or participating in activities with friends, had reduced endurance. This was really quite an eye-opener. Patient and advocacy groups have brought attention to disability associated with post-COVID conditions. And so it's really important as we are formulating policy and protocols that we include patients and caregivers and include them especially in designing research studies. This can be a very debilitating condition, at least for some. In terms of the ADA, the Americans with Disability Act, a person with long COVID, post-COVID conditions has a disability if the person's condition or any of its symptoms is a physical or mental impairment that substantially limits one or more major life activities. CDC has put out interim guidance for post-COVID conditions, the clinical care. Again, these are likely to change over time as we learn more about these conditions and what works and what maybe doesn't work so well. Most of these conditions, post-COVID conditions, can be diagnosed and managed by primary care providers. Many of these conditions can be diagnosed based on history and exam. In many cases, the routine tests are normal. If these symptoms persist beyond 3 months, though, then further investigation, further evaluation may be warranted. And it's really important. This is probably the most important thing on this slide. Listen to and validate patients' experiences. Partner with the patients to identify achievable health goals. Again, the frustration level for many of these patients is high because they've had such difficult experiences within the healthcare system. Key points: 1, new or persistent symptoms lasting more than 4 to 6 months can occur among patients with COVID-19, regardless of their acute illness, hospitalized or mild outpatient, or age, although more likely to occur in people with more severe disease. In addition to respiratory symptoms, patients can present with fatigue, sleeping difficulties, depression, anxiety, neurological dysfunction. We've talked about those neuropsychiatric diagnoses, cardiac manifestations, kidney, as well as new onset diabetes, new or worsening chronic conditions. Objective clinical findings in multiple organ systems have been reported among patients with COVID-19, again, including development of new chronic conditions, but many patients do not have positive laboratory tests or radiographic studies. They have conditions that may be debilitating, but do not correlate with a specific organ-specific pathology. There's still a lot we don't understand. Empathy towards patients experiencing longer-term COVID-19 health effects is really, really important. And especially as you work with these patients' rehabilitation, recognize that, especially again, as I said before, pushing them too fast or too hard can precipitate this post-exertional malaise and set them back a bit. In terms of CDC's ongoing efforts to understand these post-COVID conditions, we're partnering with clinicians to gather information from the front line, from the trenches, analyzing electronic health data. And we've also established a number of cohort studies to better understand the natural history, the clinical course of these conditions, as well as things that seem to work or don't work for them. We have done quite a bit of communication and outreach, including this talk to you today. You can go to our website for a variety of resources on post-COVID conditions. And here are some of the web links that are in the presentation and hopefully available to you. And with that, I'll go ahead and wrap up. There's actually an email that you can, if you've got questions that you don't find answers to, you can email our post-COVID conditions unit at this email here. With that, I'll open it up for questions if there's still time.
Great, thank you. All right. Here's some questions. What are the COVID transmission rates for people who are vaccinated versus those who are not vaccinated? Also, approximately what percentage of the population would need to be vaccinated to achieve some level of herd immunity?
Those are excellent questions. What you're taught, the first question is really asking about vaccine efficacy. How effective? What level of protection would you expect? That depends a little bit on the population and has been a little bit different with Delta variant compared to some of the earlier variants. But ranges of vaccine efficacy, and it depends a little bit on the particular vaccine as well, and whether someone's received a booster and whether they have a healthy immune system. But those vaccine efficacy for preventing infection have ranged from 60 to as high as 90+%. Now, the protection against serious illness, hospitalization, and death tends to be much higher. Now, the second question had to do with what percentage of the population needs to be immunized to achieve so-called herd immunity, or I like the term community immunity, because I don't tend to think of people as herd animals. But and again, that is a really good question that I'm not sure we have a perfect answer to at this point, especially with this Delta variant. Part of the factors that contribute to that is what other kinds of measures that we're taking. You know, are we wearing masks? Are we avoiding, you know, crowded conditions that produce intense exposure? This is a particular concern in some congregate living settings where you have to vaccinate pretty much everyone in order to slow down or eliminate the transmission. It also is complicated by the number of people who have natural immunity. If half of the people have already been infected, you may not have to immunize as many. Although, as I've said before, those who have already been infected can get even higher levels of protection if they're immunized as well.
Okay. We're reading about individuals having difficulty being approved for disability benefits for post-COVID syndrome. I'm curious to know if the CDC has been approached by the Social Security Administration officials to provide disability-related data about post-COVID-19 syndrome.
That is a really good question, and I'm going to say someone on our team may have the answer to that. I unfortunately don't. That might be a good one to email to our post-COVID conditions team, because you know, this is an evolving situation, and this is a really challenging situation for patients and providers because this is new, and oftentimes our systems take a while to catch up with the reality.
True. Okay. Is there research to suggest that COVID vaccine may be recommended on a yearly basis to provide ongoing protection similar to seasonal vaccination recommendations for the flu?
That's also a really good question, and I think it's sometimes attributed to Yogi Berra. It's difficult to make predictions, especially about the future. And this is really new. This is emerging. Before making recommendations about boosters, we really want to see the data. We do know that at least for certain populations, for certain individuals, a booster at 6 months provides additional protection, at least additional protection against infection. They're already pretty well protected against serious illness and hospitalization. Whether we're going to need an annual vaccine or not, no one really knows at this point. Part of the challenge has been how much of this has been due to waning immunity and how much has it been due to changing variants. 6 months ago, it was not, Delta variant was, was a rare thing. And now almost all the SARS coronavirus 2, at least in the US, is Delta variant. Now, Delta has hung on to its market share, and so it may not let any others in. If so, it'll be easier to understand the effects of waning immunity versus changing variants. But the short answer is, I don't know, and no one really does at this point.
Do these post-COVID conditions that you discuss include both vaccinated and non-vaccinated people?
Most of these post-COVID conditions have been seen in unvaccinated, non-vaccinated individuals. As I mentioned, we do see some in breakthrough infections in vaccinated individuals, much less likely in, at least in that study from the UK, 50% likely, but we do see some. We don't have a lot of data on post-COVID conditions specifically in vaccinated individuals, just because it's not that common.
Are post-COVID phenomenon seen in people that receive monoclonal antibody therapy? If so, at the same or different rates? And what if they were a breakthrough case that received antibody therapy?
These are great questions, and hopefully ones that we can answer with ongoing observations and study. I don't think we have the numbers yet to really make a definitive statement on that. So stay tuned on those questions. Great questions, though.
We're still doing good on time. is it possible to determine if a person has had COVID after they have been vaccinated?
Read that question for me one more time. I want to make sure that I'm answering what's being asked.
Is it possible to determine if a person has had COVID after, meaning if a person was vaccinated, is there a way to go back and do a test to see if they had COVID before? So like they may have had COVID, but then they got vaccinated.
Yes, actually there is. I mentioned early on in the talk on that virology slide that I probably spent way too long on. If we look for antibody to the spike protein, both people who are vaccinated and those who have had natural infection will have antibody to spike protein. But if we look at antibody to that nucleocapsid protein, which is inside the virus, only those with natural infection would have antibody to nucleocapsid, because the vaccines either give a version of the spike protein or they give mRNA that produces a version of the spike protein. So if you had someone who had been vaccinated and you wanted to find out, did they have COVID? In fact, did they have SARS coronavirus 2 infection before they got vaccinated? You could do an antibody test for nucleocapsid protein. And if it was positive, you would know that they had also had natural infection. So yes, that can be done. Now, if you want to find out whether they have current infection, yeah, a PCR or an antigen test would tell that.
Okay. Is there a connection with long COVID and overstimulation of the immune system or autoimmune disease? That's a good one.
Yeah, that's a really good question as well. Something we're looking at very carefully. The evidence that suggests possibly so is one, as I mentioned, with the cardiac conditions, there is evidence in many patients of heart muscle inflammation on MRI a couple months after diagnosis. Some of these conditions that we see, like diabetes, thyroiditis, could be immune mediated. And then in children who have had this multi-organ inflammatory syndrome, which is an immunologic disease, they are somewhat more likely to develop post-COVID conditions. So there may be part of it that is immunological. Certainly these patients who are having symptoms months after their initial infection, especially those who are 6 months, there's no detectable virus in their body. So whatever is causing it is probably not directly due to the virus itself, may well be an immunologic response.
A comment here. Thank you so much for emphasizing that physicians need to listen to and believe post-COVID sufferers. As someone who has it 1 year now, that's the biggest hurdle we face. And I think that, having you reinforce that in your presentation, I have 2 cases right now where people are applying for long-term disability, and one in particular was denied because, well, it doesn't show up on a brain scan, so you must not be having these issues of fatigue and memory. And actually said, well, they're having some kind of conversion disorder as opposed to long COVID. So I think that that statement just kind of stresses the importance of people's frustration with not being heard.
Yeah, I really empathize with these patients, and I really that comment is really pertinent. Now, I should say, just because someone had COVID in the last 6 months doesn't mean everything they're presenting with is post-COVID. We still have to look for other diagnoses. We don't want to miss another diagnosis just because they happen to have COVID, but we do need to listen to our patients. One of the hardest things for us as healthcare professionals to say is I don't know, or I can't explain that, or I'm still learning about this. But with a new and emerging condition like this, I've tried to be a good example of that behavior, is just say, we don't know everything. And I certainly don't know everything, and we're still learning. And each of you who see patients with post-COVID conditions, you're contributing to our community experience, our collective experience with these conditions. And so keep an open mind and an open heart to these patients as well. And we'll keep learning together.
What is the best antigen test to do if vaccinated? When would it be best to have this test done? How long after vaccination?
An antigen test is used to detect active infection. And if someone had an exposure, or you were screening them for going into a nursing home or whatever, or they had symptoms, then there's a variety of antigen tests that could be used. It'd be the same choices and the same factors as someone who wasn't vaccinated, and that some of these antigen tests may be more available, may be more convenient. Now, if the question was an antibody test to look whether they have antibodies, we don't routinely recommend antibody tests after vaccination because they don't really give us, in most cases, clinically useful information. People who get vaccinated, they develop antibodies. That's what vaccines do. And we don't have a perfect correlation between the levels of those antibodies and how much protection. There's a lot of things that can affect how protected you are. Now, the exception to that may be people with immunocompromising conditions. And it may be appropriate in those cases, 1 or 2 months after vaccination, to do an antibody test to look and see, did they generate any antibody response at all? What we are doing is recommending that those individuals do get we're not calling it a booster for them because we're trying to get them a primary immunologic response. But after they receive the 2-dose mRNA, either Pfizer or Moderna series, to go ahead and give them a 3rd dose, at least 28 days, at least 4 weeks after that 2nd dose, regardless of what the antibody levels are. And the reason is if there's no antibody, we're trying to get an antibody response. If there's some antibody, we're trying to boost that. So it's a long answer to a very simple question, maybe a question that you weren't even asking. But the clinical utility of antibody levels after vaccination is not really clear at this point. And our recommendations for those immunocompromised individuals and those booster recommendations are based on general populations not requiring an antibody level to be done.
As you say, this is evolving and a lot more research needs to be done. What areas of research are lacking, not being addressed at all, and what areas are currently going on that you're excited about?
There's a lot of research going on in this area. I summarized broad categories with CDC, but NIH is also very engaged in this. And a whole variety of questions, some of the questions that you all have asked, and hopefully we'll have some answers to, like the effective monoclonal antibodies, the effective vaccines, and various treatment modalities that are being used. But obviously there are more questions than we have answers at this point, and some of the questions we don't even know to ask. And that's why part of our strategy is to work with you as clinicians, because your experience may inform the questions that we ask and the research that we fund.
Are there any long-term studies on post-COVID syndrome currently ongoing, and what do they show?
Yes. As I reported, some of these studies have gone out a year, like that VA study, but we have cohorts that CDC has been following. And then we also are able to get at some of those answers by looking at electronic databases, because they have the whole medical record for patients. They're not as good as a cohort study where we're carefully following them, carefully watching them, but those studies are ongoing.
Has the CDC done studies as to why healthcare professionals refuse to get the vaccination?
Now, that's a good question. Boy, we could spend a long time talking about that particular issue, and maybe that would be a wise use of our last 15 minutes, but I won't do that. I would say that not just in the United States, but around the world, we have what we're also calling an infodemic. So much information, including disinformation and misinformation out there, it can be confusing for a lot of people in terms of what do I believe and who do I believe and what's the right thing to do. Now, for healthcare professionals, hopefully they have the ability to filter out a lot of the stuff, but it still can be confusing if you're not an epidemiologist or if you're not an infectious disease specialist, sorting out, fact from fiction. But I would hope that of our healthcare professionals would be very discerning in the voices that they listen to and pay attention to the emerging science on this. Just because we don't have all the answers doesn't mean we don't have enough information to make good, wise, informed choices. And I think particularly with regard to vaccine, there's a clear preponderance of evidence that it's highly protective and as safe as any vaccine that we've had out there. And I think it's a good idea for us as healthcare professionals, not just protect ourselves and our families, but also our patients who we come in contact with.
Here's another one. I heard the PCR test may be discontinued in December 2021 due to too many false positives. Is that correct?
No, the PCR technology is, we have a lot of different types of PCR tests. It's our most sensitive test for picking up a lot of different types of viral infections, but particularly with SARS coronavirus 2, our most sensitive test. Now, when they say false positive, they're not generally false positives in terms of the person's not infected at all. It's that those PCR results can remain positive much longer than the patient is still infectious. There's still detectable viral RNA even after the person is no longer infectious to other people. So mostly it's just being careful how we use that test. It's great for diagnosing acute infection, but if someone's already tested positive, repeating that test, 2-3 weeks later, you're likely to get a positive test and someone's not infectious to other people. Now, if someone had an asymptomatic infection and no one tested them then, they recovered from it and they weren't infectious to other people, and then they had a PCR screening test that may turn positive, and it looks like they have an infection then. They had an infection a few weeks ago and they're no longer infectious. That you could call a false positive in that case, but it's not a true false positive. They did have an infection and they still have viral RNA that's being detected.
Okay. In terms of employment and type of employment setting, is there data regarding increase of risk of COVID infection risk for occupations performed primarily inside versus outside? For individuals working primarily outdoors, does the data suggest, in addition to being vaccinated, that mask wearing is recommended or more effective than vaccination alone?
The question about outside, the risk of COVID transmission in most outdoor settings is very, very low. Now, there are some cases where there may be high levels of community transmission and very crowded outdoor settings where it's impossible to maintain any kind of social distancing, where it may be still wise to wear masks. But in most cases outdoors, because of the ventilation, because of the spacing, the risk of COVID transmission is already pretty low, especially for people who are fully vaccinated.
And which test is recommended for workplace routine monitoring of employees?
That's a good question, a question that's probably too complicated to give a one answer to. The best I can do on that is give some general principles. It really depends on the type of work. Are we talking about fully vaccinated individuals or not? And then what type of resources or turnaround is available? The antigen tests are very helpful in those situations because you get an answer right away. Now, there are some situations in which you can get a PCR answer very quickly as well, in which case a PCR is more sensitive. If you use it in the right setting, then it may be a better test for screening. But in most cases, antigen tests are really quite good, and you get your answers back right away. Sometimes having an answer right away is better than having the best answer a day or two late.
And here's the question that I've actually wondered about. How do you know if, when you're testing, if it's the COVID or the Delta virus, if you cannot isolate the virus?
Well, your antigen tests are not going to be able to tell you which variant it is. A PCR test, just a normal PCR test, doesn't tell you what variant. They could take the sample then and do what we call a genotype to determine the variant, and that's done on a percentage of cases, just so we know nationally what we're seeing in different parts of the country. Now, in the US right now, virtually 100% of the cases are Delta variant, so it's not that helpful to do genetic testing for that purpose. What we're doing is we're doing genetic testing to see what kinds of subvariants of Delta may be out there. Right now, there's not a clinical difference between this variant and that, but it gives us the chance to see what's happening and assess whether there's any impact to that or not. But for clinical cases, there's no reason to know whether it's a Delta variant or not. It's almost always going to be a Delta variant.
And I think that's some of the confusion maybe for me is when folks go in the hospital, they're just testing positive for COVID. So is there an advanced test that's testing that it's, so they know it's the Delta variant, or they just automatically assume it's a Delta variant?
Well, at this point, we automatically assume it's the Delta variant because almost all of them are. What we are doing is the labs that do those tests, they send a certain proportion of those tests on for genetic testing, for genotyping. And that's how we know what's going on. Actually, I had in this presentation a nice slide that showed the percentage of Delta variant, but I thought, since it's almost 100%, that's a pretty boring slide. Let's cut it out. Now I wish I had kept it in.
If you take the mRNA vaccine, does that permanently alter your DNA?
No. The messenger RNA never even enters the nucleus of the cell. It doesn't affect the DNA at all. What it does is it allows for protein synthesis of this version of the spike protein that will be stable outside the cell and will allow the body to make antibodies against it, so that when it sees that spike protein on the surface of a virus, it's all ready to attack and neutralize.
And I think this may be the last one, a statement, and I'll ask you to comment. I had a doctor report a high level of nasal infections from not changing masks frequently.
Nasal infections. I'm assuming that's other types of nasal infections, not COVID infection. I hadn't heard that. If there's nothing inside that mask that wasn't already in your nose, but I guess if someone, for example, was carrying Staph aureus in their nose and their nose stayed moist all the time, that it might make it a little worse. I'm kind of speculating at this point. I think that once your mask gets soggy, it's definitely time to change it. You know, so yeah, we have to practice good mask etiquette, just like you know,
And
you
wash.
change other PPE. You got to change your gloves. You got to change your gown. You do have to change your mask from time to time.
Great. All right. Thank you so much. I think that we were able to answer all the questions, which is awesome. Dr. Smith, thank you again so much for being with us. It's been very informative, and I really appreciate you joining us.
Thank you, Julie, and thank you to all who are listening. And I wish you all the best as you care for these patients and others. Stay safe.
Thank you. Take care.